We are live now.
Good evening to all. Welcome to today's ITS Clinics session. So today we have a case presentation by endocrine surgeon team. We'll start off with the So welcome our coordinators, Dr. Pramila Kalra and Dr. Roma Pradhan. And welcome to Dr. Krishna Shadri sir, President of ITS, Dr. Arun Menon, Secretary of ITS, Dr. Mini Pillai, Treasurer of ITS, and Dr. Chitra Selvan and Dr. Ganavi. So today session we are having...
Hi, Vijay.
Hello, sir. Good evening, sir.
Good evening, Vijay.
So today we are having a case presentation on stridor due to thyroid disease challenges in surgical management, presented by Dr. Shraddha Srinivas, MCH Resident, Department of Endocrine Surgery, Madras Medical College. Session will be moderated by Dr. Talapati Sadacharan, Professor and Head, Department of Endocrine Surgery, Madras Medical College. Dr. Roma Pradhan is not able to join. And then we'll have a monologue on thyrotoxicosis, myriad of presentations by Dr. N.K. Narayanan, Consultant Endocrinologist, Apollo Hospital, followed by quiz by Dr. Nivedita Karthika, Consultant Endocrinologist, Anya Endocrine Diabetes Center, Madurai. So, our President, Dr. Krishna Shadri, sir, is there. Sir, you would have a...
Good evening, everyone, and thanks for joining the thyroid clinics. This clinics has gone from strength to strength and has seen increased participation over time. It is a privilege of my presidency that this has become a fantastic movement that has nurtured one collaboration between the various specialties that take care of the thyroid. It's also my pleasure to see greater degree of involvement from everyone. I will be laying down office as president next month, so this will be my last clinics as president and my nth clinic as just an observer and happy participant. So I just wanted to take that half a minute from this time to thank all of you for your participation. This has been such a great privilege for all of us that you have considered the ITS as a partner in your knowledge and your growth. We want you to continue to do this. I also request you to consider converting some of these excellent cases. We will be compiling these cases. Pramila is compiling these cases that will be part of the release during the ITS con. I also invite all of you to join the ITS con in Mumbai this year on 15th and 16th. Please also submit your abstracts to Indian Thyroid Society. We are the only society in India where the abstracts actually get published in the journal, which means that you already have a publication when you have submitted your abstract. So please do that. And also please consider contributing articles, being reviewers from the Indian Thyroid Society. Thank you very much. And again, thanks Vijay Bhaskar for putting this together. A little extra special for me because members of my home state are presenting and participating in a large number today. And what better can someone ask when his home crowd turns up for his last performance? Thank you so much, Vijay. Back to you, and I wish all of you the very, very best.
Thank you, sir. So today, For the first case presentation, we are having a moderator, Dr. Talapati Sadacharan, Professor and Head Department of Endocrine Surgery, Madras Medical College, Chennai. He has got numerous publications in national and international journals, and he is a very accomplished endocrine surgeon from Chennai. So I invite Dr. Shraddha Srinivas. Dr. Roma Pradhan, madam, could not join. So I invite the case presenter, Dr. Shraddha Srinivas, MCH resident, Department of Endocrine Surgery, Madras Medical College, to take over the session and present the case. Thank you.
Thank you, sir. I'll share my screen right now. Good morning, everyone. Good evening, everyone. I'm presenting this topic on stridor due to thyroid diseases, challenges in surgical management. So I'm going to present 4 cases that we encountered in our department where patients presented with stridor and regarding the surgical challenges that we had to undergo. This is the case number 1. It is a 55-year-old male. He presented with stridor. He had a swelling in the front of the neck for the past 3 months. He had difficulty breathing for the past 7 days. There was no complaints of any hoarseness of voice, dysphagia. There was no history of any hypo or hyperthyroidism. On local examination, we found a 3 x 2 centimeter hard swelling over the right lobe region of the thyroid. However, the left lobe was not palpable. The lower border was palpable, and there was no lymph nodes which were palpable. The systemic examination was within normal limits. He was a euthyroid patient. On ultrasound, we found that there was a thyroid spine nodule of size 3 x 3 x 2.5 centimeter on the right lobe. Left lobe was normal. There was no cervical lymph nodes. We did a CCT neck. So this is the CCT image where you can see that there is in the right lobe, there is a lesion which is infiltrating the trachea, involving the second to the fourth tracheal cartilage. So the FNAC was done from the right nodule. It was papillary thyroid carcinoma. The VDL showed bilateral vocal cords were mobile. So we also did a bronchoscopy. This is the bronchoscopic picture where you can see a 0.5 to 1 centimeter luminal infiltration involving the second to the fourth tracheal cartilage. So we proceeded with the total thyroidectomy and resection of the tracheal second to the fourth ring with suprahyoid and hilar release. And subsequently, a primary end-to-end anastomosis was done. So this image shows the endotracheal tube that is placed inside after the resection of the tracheal cartilage from the second to the sixth, and also the thyroidectomy specimen. Here, this is where we are taking sutures for primary anastomosis from the 7th cartilage. And this is from the 1st cartilage. And finally, this is the final anastomotic picture where you can see the primary end-to-end anastomosis that is done. And also there were tension release sutures were also applied. So this is the gross specimen. This is the posterior surface. So you can see that this is the gland which has been, the thyroid mass which has infiltrated into the tracheal cartilage. So on the immediate post-operative period, the patient was extubated. Bilateral vocal cords were mobile. His voice was normal. The patient was comfortable. So this is the immediate post-op picture of the patient in OT. He maintained his neck position for 10 days, and we gave Ryle's tube feeding for 7 days, followed by normal diet was given. So the final histopathology came as oncocytic subtype of papillary thyroid carcinoma, and the tumor size was 3 x 2.5 x 2.2. It was unifocal. This is a photomicrograph showing the tumor infiltrating the tracheal cartilage. This is the follow-up picture on postoperative day 15. 1 month post-op, the TSH was 39.85. The stimulated TG was 3.84 and ATG was 18.31. The patient is planned for iodine 131 therapy. So this is a video showing the patient's voice as well as the neck mobility.
பண்ணுங்க இந்த பக்கம் மேலே கீழே இப்படி 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 இந்த பக்கம் பேர் சொல்லு நார்மலாக ஸ்ட்ரெயிட்டாக பண்ணுங்க
Kamal
Ah.
Zaman.
So you can see that there is no restriction of neck movements and the voice is completely normal. The second case is a 34-year-old female. She presented to the emergency department with stridor. She had a swelling in the neck for the past 6 months, and she gives a history that the size of the swelling increased over a period of 15 days. She has been having this breathing difficulty for the past 3 days. On local examination, we found that there was a 8 cross 7 centimeter hard swelling in the anterior aspect of the neck, and bilateral level 2, 3, 4, and lymph nodes were present, with the largest measuring 3 cross 2 centimeter. The inferior border was not palpable, whereas the carotid pulsation also could not be felt. She was euthyroid, and the CT scan, this is the image where you can see a diffusely enlarged thyroid swelling. Here you can see there is a tracheal narrowing that is visible, and also these are the lymph nodes. There were multiple lymph nodes which were enlarged in the mediastinal and also in the level 2, 3, 4, and 5. FNAC was, however, benign. It came as Bethesda 2. A core biopsy was also done initially in this patient. It was reported as Hashimoto's thyroiditis, but however, thyroid lymphoma could not be ruled out. So this was the VDL of the patient before intubation. Here you can see that this is the left false vocal cord, which is edematous, and we could not visualize the left vocal cord, true vocal cord. This is the right vocal cord, which was visualized. However, the mobility could not be assessed. So as the patient presented in emergency in stridor and also with desaturation, patient was intubated. Awake nasotracheal intubation was done. This is the picture showing the same. And this was a 5.5 mm ET tube was inserted. So we planned for a total thyroidectomy for this patient. So this is the intraoperative picture that you can see. This is the thyroid specimen. It was completely plastered and it was very difficult to dissect this thyroid specimen. There were planes with the trachea, the carotid, and the IJV was not easily felt. And at the same time, we were not able to identify the bilateral recurrent laryngeal nerve. So this is the post-thyroidectomy. We were able to do only a debulking thyroidectomy, and this is the thyroid bed post-resection of specimen. So we went ahead with a debulking thyroidectomy, and a level 5A lymph node was also sampled. So in the immediate post-operative period, patient was extubated, but immediately went into stridor. She desaturated, so we had to re-intubate her, and also a tracheostomy was done. On post-operative day 2, she was weaned off the ventilator. She was completely comfortable in room air in TPs, and we changed the tracheostomy to a speaking valve tracheostomy. So the final histopathology came as a classic Hodgkin's lymphoma. Now, on follow-up, she is completely stable. She is comfortable on tracheostomy tube, and she has completed her first cycle of chemotherapy. The regimen that was given was ABVD regimen, that is adriamycin, bleomycin, and vinblastine and dacarbazine regimen was given. The third case is a 4-year-old male. He presented with respiratory distress and stridor to a pediatrician. He was shifted to a pediatric ICU, and following desaturation, the patient was intubated. The patient's mother gives a similar history 10 days back, where the patient was treated by another pediatrician, and they thought the patient was having wheeze and induced respiratory distress. So the patient again was kept in an ICU. He was also intubated 10 days ago. And once the symptoms had resolved, he was weaned off, extubated, and discharged. So on further history, they gave this thyroid swelling was present for the past 1 year. They also gave a history of increase in the size of the swelling for the past 3 months. On examination, it was a 6 cross 5 centimeter diffusely hard thyroid swelling. It was non-warm, non-tender. There was no nodules that were palpable. The inferior border was visible and palpable, but there was no cervical lymphadenopathy. On systemic examination, his respiratory system, the bilateral air entry was completely normal. There was no added breath sounds. There was normal vesicular breath sounds were present. So since the patient was had desaturated, he was intubated and was in pediatric ICU. So further workup was done. This was the initial chest X-ray where the chest was completely normal, and you can see the soft tissue shadows of the thyroid gland, which was enlarged. So this was the CT image that was obtained after intubation. Here you can see a diffusely enlarged thyroid gland. And also this is the endotracheal tube that is in situ, and this is the Ryle's tube that is in situ. So the CT report stated that it could be either an early Hashimoto's thyroiditis or an acute suppurative thyroiditis. This is the coronal and sagittal section, which shows the diffuse thyroid gland, which was enlarged. And this was the endotracheal tube that is in situ. So the procedure, we proceeded with total thyroidectomy. So this was the intraoperative picture. So you can see that the thyroid gland here also was very difficult to mobilize from the adjacent structure. It was stuck onto the trachea with great difficulty. It was separated from the carotid. So we were able to identify both recurrent laryngeal nerve, and we were able to preserve this. This is the left recurrent laryngeal nerve that was identified and preserved. And this is the right recurrent laryngeal nerve, which was identified and preserved. However, there was no pus discharge from the thyroid gland. This is the postoperative thyroid bed after total thyroidectomy. This is the specimen. This is the anterior view, and this is the posterior view. So in the postoperative period, patient was shifted to ICU and was intubated. In postoperative day 2, patient trial extubation was conducted. The following extubation, the patient was stable. He was maintaining saturation in room air. The voice was normal, and there was no hypocalcemia. The final histopathology came as Langerhans cell histiocytosis. So this is an image showing Langerhans cells of the specimen. We were able to get four lymph nodes from the perithyroidal adipose tissue, where 3 out of 4 showed atypical histioid infiltrates. So this was IHC that is positive for Langerin antibody, and this was IHC that was positive for CD1A antibody. So on follow-up, patient was stable, comfortable, and there was no respiratory distress. So we decided to do a FDG PET scan to rule out any other metastatic lesions. So there was a metastatic lesions in the scapula. So he was started on chemotherapy. The chemotherapy that was given was vincristine plus corticosteroid. It was given weekly once, and it was given for the plan was to give it for 6 weeks. Now the patient has completed his first cycle of chemo. The last case is a 75-year-old female. She presented in the emergency department in respiratory distress and stridor. She was intubated and admitted under cardiothoracic ICU. So they did a CT scan of the chest to see for other pathology, and they found a large retrosternal goiter. So patient gave a history of an anterior neck swelling for the past 10 years. She also gave a history of cough for which she had taken treatment for the past 6 months, but there was no improvement, and rather there was a worsening of the cough. She also complained of breathing difficulty, which was more for the past 7 days. There was no features of hypothyroidism or hyperthyroidism. On local examination, there was a 6 x 5 centimeter firm thyroid swelling that was noted. And the inferior border of the left lobe was not palpable. There were multiple nodes that were palpated in both lobes of the thyroid. So this was the CT image that was taken after the patient was intubated. So you can see that these are the nodules that is present on the thyroid gland. This is the endotracheal tube that is present in situ. She was euthyroid. Her CT neck showed, this is the CT neck image. This is the large retrosternal component that is seen. And this is the arch of aorta. This retrosternal component has been extended up to 4 centimeter below the arch of aorta. So the FNAC was benign. It was Bethesda 2. So the plan was to proceed with total thyroidectomy, and to retrieve the retrosternal part, we planned either to follow a transcervical route if it is failed. So we planned for this sternotomy. So we were able to retrieve the retrosternal component transcervically. This is the final picture. This was the retrosternal component which was delivered transcervically. So the patient was shifted to ICU. She was still intubated after surgery. The next day, she was extubated. Her vitals were stable. Her voice was normal. She was very much comfortable on room air, and she maintained her saturation. On final histopathology came as thyroid follicular nodular disease. On follow-up, she's stable and comfortable, and she's on thyroxine replacement. Thank you.
It's a good presentation, Shraddha.
Thank you, sir.
Dr. Narayanan and Reddy have any queries regarding the management and the case?
Can I ask?
Yeah, please.
So often when there is a long-standing retrosternal goiter which has been compressing the trachea, how often do we see the tracheal collapse requiring, like the cases what you have showed with intubation, prolonged intubation? Because often they say that for the larynx to come back to its original position from the collapsed thing, it may take a longer time.
Yeah, the thing is, if the trachea has been compressed in the cervical part, what happens is that there will be thinning of trachea. We will actually assess the tracheal thinning or any destruction of the trachea over a long-standing period. We have operated patients more than 30 years, 40 years with the nodules also. So what happens is there will be thinning of trachea, and it will be like a paper. So once we remove the tumor, what happens is it get collapsed and get plastered to the posterior aspect. In that case, it might require a tracheostomy. Here, the problem is it was a retrosternal part which was compressing the trachea. It was not actually destroying the trachea to warrant a tracheostomy. It had been, the tumor has been on both sides compressing the trachea for quite a long time. That can cause tracheomalacia. But still, we thought of tracheomalacia, and we do some maneuvers to see whether the patient has tracheomalacia or not in the intraoperative period. Just like while we just pull out ask the anesthetist to pull out the endotracheal tube. If there is a collapse, the trachea will just stick to the endotracheal tube. So that is one maneuver. Another thing is there will be always a gap between the endotracheal tube and the trachea, and there will be air will be rushing. In this case, there will not be any leak test, that is called. Whether there is any leak in the between the trachea and the lumen, that also we will see. If it is not there, then we will suspect tracheomalacia. All these things we will see, and required only we will do a tracheostomy.
Case of lymphoma, I think the time initially they gave Bethesda 2, that is FNAC.
Yes. Again, where true cut biopsy was also done, Vijay Bhaskar Reddy. At the time, even the true cut biopsy, they were not sure. But the thing why we operated is because of the stridor. If the patient did not have stridor, we would have again gone for a lymph node biopsy to see, and then proceed with the chemotherapy or whatever it is. It was operated only to have the airway. To secure the airway, we had to intervene in the form of thyroidectomy in this patient.
The case histiocytosis also, I think that was a very rare case.
That case actually, he came to the OPD. He was coming to the OPD 2-3 times. We just kept in follow because a young boy, 4-year-old, FNAC was a thyroiditis. So they were asking to operate, but I just kept it so that if it requires, we will do, because with the thyroiditis, why to operate? But what happened is he got admitted under a pediatrician once. Again, they told it is due to some lung pathology and discharge. Again, within a week, again he got readmitted. At that time, it was a clear-cut stridor, and the pediatricians, they again intubated it, and we had to intervene to secure his airway in this case. And very rarely we got this as a Langerhans histiocytosis also in this case. I think we just searched on the literature, we could find not many cases in this pediatric age group, especially Langerhans histiocytosis.
Any other questions from the audience or from other panel members? I think with extensive plastering of the thyroid to the trachea, it must be very tough to operate these cases. How long does it take for surgery in difficult cases?
Yeah, actually, this pediatric case, it took around 3 hours for this surgery, 2.5 to 3 hours. And this lymphoma case took around 3 to 4 hours because it was very difficult actually.
Thank you, Dr. Shraddha, for presenting 4 cases. Thank you, Dr. Talapathy, for organizing and moderating this session. I think they showed us what extensive thyroid disease, when it affects the tracheal airway, how difficult it is and how challenging it is for managing these cases with Stridor. Thank you.
Thank
We
you.
move on to the. Thank you.
Thank you, sir.
Thank you. So with this, we move on to the next presentation by Dr. N.K. Narayan. I think all of us know that endocrine diseases are notorious to have varied presentations, and they are great mimickers. So today we are going to have a topic of thyrotoxicosis, myriad of presentations. It will be presented by Dr. N.K. Narayan, who is a consultant endocrinologist at Apollo Hospital, Chennai. He is adjunct professor at Tamil Nadu Dr. MGR Medical University, former research associate at Cambridge University, UK. He has multiple international presentations. He was awarded the Best Endocrinologist National Award by Economic Times Award 2024, and he has multiple presentations in UK. And he has also been part of guidelines for the management of pituitary tumors, multiple book chapters and several international journal publications in journals like JCM, PNAS, and Nature, which are of high impact factor. Over to Dr. Narayan.
Thank you for the kind introduction. Okay, is the screen visible now? Is the presentation visible?
Yes.
Yes, sir. Yes, sir.
Okay.
Yes.
So, good evening, everybody. Thyrotoxicosis, myriad of presentations. That's what the topic is going to be. The moment we talk about thyrotoxicosis, the 3 most common things which comes to our mind are the Graves' disease, the toxic multinodular goiter, and the toxic nodular goiter. So, just to turn away from the routines, I've just collated 3 different various ways of presentations of the thyrotoxicosis. All these patients whom I have managed personally in the past few years time period. So the first presentation, the first patient is a pregnant lady, a 23-year-old prima gravida, 24 weeks of gestation. She presented to the obstetrician and got admitted with a 3-week history of altered behavior, confused state, inappropriate talking, and especially imbalance while she was standing and walking. She had a history of hyperemesis during the first trimester going on until the time of presentation. Prior to the pregnancy, she did not have any history of neurological or psychiatric problem, which one might think got exacerbated during pregnancy. There was a family history of hypothyroidism in mother. She was not on any medications apart from the folic acid prior to the pregnancy, but 10 days prior to the presentation, she was started on olanzapine by a psychiatrist in an outside hospital because of her altered behavior, thinking that there is a psychosis, which is new in onset in this lady. So I was called in to see her because of this feature. On examination, she was lean, weight around 52 kilograms. She was tachycardic at 110 per minute, slightly elevated temperature at 99.4 degrees, no goiter, no thyroid eye disease. She had mild peripheral tremors. Neurologically, she had the striking feature was that she had an involuntary truncal or axial movements. She was unsteady on her feet with an ataxic gait. She was mildly confused with mild disorientation. Eye movements were normal and no nystagmus. I've just selected some of the key investigations. Liver function test showed an elevated transaminase ALT of 333, normal renal function. ECG confirmed the clinical finding of sinus tachycardia. And based on the clinical suspicion, the thyroid function tests were done, which showed a low TSH at 0.02, an elevated total T4, and an elevated total T3. So essentially, we've got a pregnant lady in her second trimester presenting with thyrotoxicosis, which is new in onset, and along with this, most importantly, neurological manifestations. Now, when we talk about thyrotoxicosis and neurological manifestations, things like thyroid storm, this can present with the neurological manifestation as well as with cardiovascular manifestations like heart failure. But in this lady, the entire picture was not keeping in with the thyrotoxic crisis. Her presentation was to do with ataxia, gait, confused, disoriented. So not entirely keeping in with the thyrotoxic storm, nor her cardiovascular status suggests so. When I first saw her, this was 2015. I'm sorry for my bad handwriting, which has now become worse. The first thought process was whether this is thyrotoxicosis associated Wernicke's encephalopathy, not so commonly seen, but can happen during pregnancy, or whether this is gestational thyrotoxicosis, which is because of hyperemesis, and the involuntary movements were triggered by the olanzapine, which was started by the psychiatrist outside. But on questioning, mother told that the involuntary movements predated her commencement of olanzapine. So my first thought was whether this could be thyrotoxicosis associated Wernicke's encephalopathy. This is the management plan which I wrote to confirm whether it is Graves' disease, TSH receptor antibody, started on thiamine 200 milligram twice a day, started on neomecazole, carbimazole 10 milligram BD, and asked for a repeat liver function test after 2 days because she already had an elevated transaminase, which can happen during a thyrotoxic active phase, but we are starting on ATD also. We do not want this to get exacerbated post-ATD. Importantly, I wrote that they should avoid giving dextrose infusion, which is what they have been giving from the time of admission for 24 to 48 hours before I saw her. Dextrose infusion to hydrate herself and give some nutrition. This was under the obstetricians. I'll come back to as to why we wanted to avoid dextrose infusion. Based on my clinical suspicion of Wernicke's encephalopathy, I also asked for an MRI brain, which confirmed that the changes suggested that it could be early stages of Wernicke's encephalopathy. Now, Wernicke's in general, the mechanism is that thiamine pyrophosphate is an essential cofactor for several enzymes in the Krebs cycle and the pentose phosphate pathway. Brain regions which has got a high metabolic requirement are subject to this problem when there is thiamine deficiency, especially medial thalami, mammillary bodies, and pectoral plate of the midbrain. So thiamine deficiency in that sense can cause Wernicke's encephalopathy when the deficiency is acute, or Korsakoff psychosis when it is a bit more chronic in nature. So what are the factors that precipitated Wernicke's in our patient? Being pregnant, there is an increased need for nutrition, increased need for thiamine. She had hyperemesis, therefore there is a decreased intake and there was poor absorption of thiamine. The hyperthyroidism itself drives the metabolic pathways. The metabolic pathways get upregulated, thereby there is an increased need for thiamine in general. On top of all these things, so the combination of this, the pregnancy, hyperemesis, hyperthyroidism, all three in combination itself can increase the demand for thiamine and can cause a subtle thiamine deficiency. On top of which, if we administer glucose, the glucose, remember, the thiamine is an essential cofactor for all the carbohydrate pathways, which we mentioned, that Krebs cycle and the pentose phosphate pathway. So administering glucose feeds these pathways because there is an increased upregulated cycles with the hyperthyroidism anyway. When the cycles are upregulated, the existing thiamine also gets utilized and thereby it depletes the thiamine stores further, causing a deficiency state. So this administering glucose, hyperthyroidism, hyperemesis, everything put together caused Wernicke's in our patient. So the day after, within 24 hours after stopping dextrose infusion and giving thiamine and starting the carbimazole, there was significant improvement in her clinical condition. The carbimazole might have started acted slowly, but I think mainly in the first 24 hours, it was stopping the dextrose infusion, which was driving the cycles, and giving thiamine to replenish the store, both of which showed good results. By day 4, she got discharged and she was completely back to normal. The olanzapine was stopped. Although we often don't see such neurological manifestation with thyrotoxicosis, there are rare presentations like Wernicke's, as we saw in our patient, chorea, bulbar palsy, and seizures. I had another gentleman, elderly person, who presented to the gastroenterologist with quite significant dysphagia and progressive bulbar palsy. The investigated, nothing could be found. Ultimately, the thyrotoxicosis was treated. The bulbar palsy eventually resolved completely. So the learning points from this case is hyperthyroidism and hyperemesis can precipitate Wernicke's encephalopathy during pregnancy. Definitely avoid administering dextrose in such cases until the thiamine stores are completely replenished, and complete recovery is possible if diagnosed and treated early. The second patient is a man with cardiomyopathy, a 49-year-old male with 2-year history of what would suggest that he's got thyrotoxicosis, sleep disturbances, tiredness, palpitations, tremors, etc. But it went on for a bit because of his past medical history, which included a dilated cardiomyopathy, which was diagnosed in 2006, which was thought to be related to alcohol intake. He had history of non-sustained ventricular tachycardia, history of depression, paranoid disorder. So it's very easy to put down all these tiredness and non-specific symptoms to his pre-existing psychiatric problems. Those were his medications at the time of presentation: bisoprolol, ramipril, aspirin, spironolactone, atorvastatin, and furosemide. Strong family history of dysthyroidism. Mother had thyrotoxicosis, which was diagnosed in 1955, for which she had a subtotal thyroidectomy. Subsequently, she was commenced on thyroxine much later. One sister had hypothyroidism and another had hyperthyroidism. So very strong history, which would suggest a coexisting autoimmune thyroid disease in the gentleman who we are seeing also. Multiple members of the family also had cone dystrophy, which led on to blindness, but patient himself is negative for that particular mutation. On examination, he had an elevated BMI. Pulse was 80 per minute. This was on bisoprolol. He had fine tremors, small right-sided goiter, no proximal weakness, no thyroid eye disease, and the clinical suspicion was thyrotoxicosis query cause. Given the strong family history of autoimmunity, possibly he could also have a Graves' disease. Those were his initial investigations, which showed an elevated free T4, elevated free T3, but the TSH was not suppressed. As one would anticipate with your Graves' disease or toxic multinodular goiter, the first thing you see is the TSH getting suppressed, and then the T4, T3 getting elevated. But here the TSH is not suppressed, which suggests that this is not the straightforward case of thyrotoxicosis that we normally see. Interestingly, his antibodies were negative. This was done because his family history was very strong for thyroid autoimmunity. TSH receptor antibody, which is done for the Graves' disease, was also negative, which suggests that this condition is probably not related to an autoimmune thyroid disease. This was his pituitary function profile, which was done. The short synaptin test was normal. Prolactin was normal. The SHBG, the sex hormone binding globulin, as we know, whenever there is an active thyrotoxicosis due to whatever reason, it drives the SHBG high, and an elevated SHBG suggests that possibly this patient has got a true thyrotoxicosis and not because of something else. Thyroid tests were done in different platforms, which were replicated. This is Siemens, Centaur, and Delphia. Both showed very similar results where the TSH was unsuppressed and an elevated free T4 and an elevated free T3. So 3 important differential diagnoses we think about when we have an elevated thyroid hormone with an unsuppressed TSH. Either it could be an assay interference or resistance to thyroid hormone or thyrotropinomas. Now, when we think about assay interference in this particular gentleman, the clinical picture is that he's got thyrotoxicosis. So the free T4 and free T3 is probably correct. Only the TSH could have been affected by a negative interference from some other substance. When we suspect TSH assay interference, we do dilution studies. So this is taking the serum sample, diluting it 2 times, 4 times, 8 times, and multifold, Then you get the values here. You multiply this by 2 to see whether this is almost the same as the baseline. This is 2.0, 2.2, 2.2. So consistently the same, which tells you that this is not because of TSH assay interference. Also, we did a PEG recovery, polyethylene glycol recovery, which showed a good recovery, again ruling out that this is not a case of assay interference, which leaves us with the next two conditions: resistance to thyroid hormone or thyrotropinomas. The TR beta mutation, which is commonly done for RTH, is negative. And this is the pituitary MRI on the left-hand panel and the CT on the right-hand panel. Essentially, the pituitary MRI showed a large adenoma. On an MRI of the pituitary, there are black spots, which indicates possibly calcium deposits, and the CT confirmed the calcium deposits. These are the white calcium deposits that we see. And calcium deposits in a pituitary tumor, generally a functioning tumor, it's thyrotropinoma. There is another condition called pituitary stone, where also you see calcium deposits in the pituitary gland. So the final diagnosis in this gentleman is thyrotropinoma. Now, how do we differentiate when we come to the last bit where there's a question about whether this is an RTH or thyrotropinomas? Many factors are taken into account. In TSH secreting pituitary adenomas, often it is not associated with the family history. The alpha subunit of the TSH is often more elevated compared to the whole TSH. SHBG, as I told you, because there are thyrotoxic picture, it is also elevated. The imaging shows an adenoma. I will not go into this at this moment. The TR beta gene analysis is normal, which is not the case with your resistance to thyroid hormone. There is often a family history when there is an RTH. The other factors are normal, and mutation is found in more than 90% when they have a resistance to thyroid hormone. So the learning points are 3 important differential diagnoses for elevated thyroid hormone with unsuppressed TSH, assay interference, RTH, and thyrotropinomas. The most important thing to take away from this is that we should not label this just as a routine thyrotoxicosis and start them on anti-thyroid medications because the TSH is not suppressed. Therefore, something else is happening. The clinical presentation should drive the appropriate biochemical investigations, and imaging and genetic testing, for example, if you are suspecting RTH, will help to arrive at a particular diagnosis. The third patient is a young lady who is wishing to conceive. Interestingly, this is my neighbor who lives in my street, presented few years ago. She was 27 at that time and came to me saying, we got an abnormal thyroid function test, and she was wishing to conceive for her second child. And from the history, it was seen that during her first pregnancy, the TSH was done. T4, T3 was never done during the entire pregnancy. The TSH was slightly elevated, and she was put on thyroxine on a minimal dose throughout the pregnancy. And after the pregnancy, the thyroid medications were stopped. There was no family history of thyroid dysfunction. At the time of presentation to me, she was not on any medications, and these were the thyroid function tests which were done as a screening test because she was trying to conceive for the second child. The TSH this time also showed a slightly elevated TSH like during her first pregnancy. The total T4 is grossly elevated, almost 2 times the upper limit of normal, but the total T3 is completely normal. Clinically, she was euthyroid, there was no goiter, and the system examination was completely normal. A repeat thyroid function test profile, which is the whole thyroid profile which was done, which again showed a slightly elevated TSH, a grossly elevated total T4, elevated total, free T4, but the T3 hormones were completely normal. The total T3 and the free T3 were completely normal. The anti-thyroid peroxidase antibody was also elevated. So the question was, this lady probably has got an autoimmune thyroid disease given her high anti-thyroid peroxidase antibody levels. Because she is clinically euthyroid, if there were to be an assay interference, it could be the T4 assay that is affected because of whatever is happening. And because the TSH is mildly elevated in the context of an elevated anti-thyroid peroxidase antibody, she could have a subclinical hypothyroidism. Now, let me explain. This was actually a case of T4 assay interference. For us to understand what is happening here and what the diagnosis is, we need to understand how the assay is done. TSH is usually done by what we call as a sandwich assay, but the free T4 and free T3 is done by what is called a competitive assay. What it essentially involves is there is a plate antibody, which is a fixed antibody, which is present here. There is a detection antibody, which is floating around here. When the T4, T3 are added, the radio labeled T4, T3 are also added, and there is a competition between the endogenous T4 and the radio-labeled T4 to bind to this detection antibodies. Once they are bound and reaches an equilibrium, depending on how much the radio-labeled T4 is bound to the detection antibody, it gives out a signal. Therefore, if the endogenous T4 is low, more of your radio-labeled T4 will be binding to the antibody, the higher will be the output, fluorescence output. Therefore, the assay will tell you that the endogenous T4 is low. The reverse is the case. When the endogenous T4 is high, the amount of radio-labeled T4 which gets bound to the antibody is low, the output is low, and therefore it is detected as having a high T4. This is the way the one-step competitive assay of T4 and T3 works. And in this lady, what happened was that she had an interfering agent, which is a variant albumin. I'll come to it as to what the variant albumin is. Essentially, this albumin, and when we talk about the binding proteins for thyroid hormones, we know that the thyroid hormones are heavily protein bound, almost 99.9%, out of which most of the T4 and T3 are bound to your thyroid binding globulin. The albumin has got a lesser affinity, but this lady had a mutant albumin, a variant albumin, which had a higher affinity for the T4. Therefore, when the variant albumin is bound to the T4, this displays the radio-labeled T4 from the sites, and this acted in that place, and therefore the output was low. That is, in the radio-labeled output was low, telling that actually the T4 is high, the free T4 is high. So this is an artifactually elevated free T4. The endogenous T4 is there. There are three people here: endogenous T4, radio-labeled T4, and the mutant albumin bound to the T4, which has got the affinity to the antibodies. And therefore, the assay is reading out saying that the level of free T4 is very high. In contrast to this, in two-step assay, what happens is the similar antibodies are there, which is the plate antibody and the detection antibody. But here, the endogenous T4, that is the serum, is first added to the assay platform, and it is allowed to attach to the antibodies first, and then the radio-labeled antibodies are added, and there is a wash step to remove any excess antibodies or interfering antibodies. Therefore, the two-step assay is thought to be better when we suspect if there are interfering agents which can give a false reports of T4 and T3. And in our patient, we did the albumin gene sequencing, which confirmed there was a point mutation in this location. And the final diagnosis is what we call as familial dysalbuminic hyperthyroxanemia. So what happens in this condition? As I told you, the mutant albumin has got a high affinity to T4. Therefore, you would expect that the actual total T4 is high. But the endogenous free T4 is actually very normal. But due to the assay interference by the mutant albumin, we see that the free T4 is artifactually high in most of the one-step assays. Sometimes in two-step assay, you can get a normal free T4. So the fingerprint for an FDH is that they have a normal TSH, elevated total T4, normal total T3, normal free T3, and the free T4 can be elevated in most of the one-step assays and sometimes could be normal in a two-step assay. So the diagnosis, final diagnosis in our patient is she's got an autoimmune thyroid disease, familial dysalbuminic hyperthyroxanemia, which is confusing the picture in our patient, and she as well has got a subclinical hypothyroidism. So the learning point is that a normal TSH, elevated T4, and a normal T3 should raise suspicion of FDH, although not common. Confirmation is by genetic screening. The biochemical picture can be confounded by coexisting autoimmune thyroid disease, like in our patient. Thank you.
Thank you, Dr. Narayan, for sharing the three excellent cases. Any questions from the audience or from the panel members?
From the audience, not as of now.
Okay. So, is it useful to screen the family members for the dysalbuminic hyperthyroxanemia?
Yes, that is advised. In fact, we had advised her mother, who also had, this lady as well, the mother had a thalassemia trait, which was also found only during this current pregnancy. Long-standing, she was labeled as just anemia. So likewise, this was inherited from her mother.
Case also was interesting that Wernicke's encephalopathy. I think you got it spot on. It's difficult in that scenario to identify and correctly classify it as Wernicke's.
Yeah, but left alone, she was labeled as a psychotic patient, put on antipsychotics, and she would have deteriorated continuously. And this was just such a quick recovery for her, just giving thiamine and stopping dextrose.
Similarly, I think in these patients in emergency, patients coming with alcohol intoxication, hypoglycemia, also normally we have to give thiamine before we start giving glucose.
Yeah, absolutely true. Very similar scenario there also.
Yes.
Administering glucose will worsen the thiamine deficiency. But here
Yes.
the other factors, the pregnancy, which is driving it, the hyperemesis, which is driving this, thyrotoxicosis, which is driving this. So there are a lot of other added factors.
So many factors. Yes. Any other comments or questions? Thank you, Dr. Narayan, for bringing out the interesting presentations of thyrotoxicosis, which is true for all endocrine diseases also, because variety of manifestations are patients, endocrine patients presenting with different specialities. This is more often the common presentations rather than a rare occasion. And I think he gave us good learning points of the three cases, and we should keep watch out for these type of presentations. Thank you, Dr. Narayan.
Thank you.
With this, we will move on to the much awaited quiz for today. So I would start off with the quiz rules. To participate in the quiz, please click on the button, attend quiz button given on the screen, which is being live streamed. The quiz will be conducted through a platform called Slido. You are requested to use a laptop for ease of experience. Quiz will run for 5 minutes. The quiz master will display case or description of question by screen sharing a PowerPoint file. There will be 10 questions. Each question will be available only once for 30 seconds with the timer on. Kindly do not refresh the page or go back to the page. So, quiz master for today is Dr. Nivedita Karthika, who is consultant endocrinologist, Anya Endocrine Diabetes Center, Madurai. She has done a DM endocrinology in Amrita Institute of Medical Sciences, Kochi. She has got the gold medal in DM endocrinology in Amrita Institute, and she is interested in pediatric endocrinology, GDM, and osteoporosis. Over to Dr. Nivedita.
Thank you, sir. Thank you for your introduction. And I think let me share my screen now.
Wait, ma'am.
Yes.
Wait for 5 minutes, ma'am. They are joining.
For the participants to join. Okay, yeah.
You can share the first slide alone, Keith.
So I'll just share the introductory part.
This first slide. Sure. I think it takes few minutes for the delegates to join. And once some people join, then we can start. We'll just wait for 2-3 minutes.
Sir, can you please announce it again? So the students can join, like it will help them regarding the quiz.
I request all the
Yes.
participants to click the quiz button on the screen, the lower part, and please join the quiz.
Actually, I think the time of the quiz we have put as 9. So some people may join that time because we are 5 minutes early, I think. That's why. Sometimes they take time.
Ma'am, you can start now.
So can I proceed?
Yes.
Yeah. So a very good evening to everyone who has joined here. So as we all know, we have 10 questions, and I'm starting with the first question. So which one of the below mentioned finding indicate a neurological cretinism? The option A, thyroid hormone replacement improves mental retardation. Patient has short stature. There will be florid signs of hypothyroidism, and there is a presence of deaf mutism.
No. Next, ma'am.
So moving on to the next question. So, the human monoclonal antibody designed to target the neonatal Fc receptor in Graves' disease, currently under phase 3 clinical trials. First option is batoclimab. Option B is efagrametor. Option C, veligrotug, and option D is certolizumab. So it is for Graves' disease, not for thyroid eye disease.
Next.
Question number 3. So the drugs that increase thyroid binding globulin concentration are all except clofibrate, tamoxifen, nicotinic acid, and methadone. Now moving to the question number 4. So all are true about primary thyroid lymphoma except. So they have a female preponderance, most commonly occurs in the 6th decade. They are commonly B-cell lymphomas, and exposure to ionizing radiation is a major risk factor for primary thyroid lymphoma.
Next.
So now we are going to the question number 5. So it is about medullary thyroid carcinoma. Which of the following is true about medullary thyroid carcinoma? The RAS mutated MTC behave more aggressively. Option B, 18F-DOPA PET can assist with identification of occult metastatic MTC. And option 3, cabozantinib has one of the highest half maximal inhibitory concentration against RET of the multikinase inhibitors, and 75% of MTCs are hereditary. So which one is true about MTC?
Next.
So now question number 6. So for children in Graves' disease, alternative treatment with surgery or radioactive iodine should be discussed and recommended, who are thyrotoxic despite taking large doses of carbimazole, the rate of 1.3 milligram per kg per day, or methimazole more than 1 milligram per kg per day. If carbimazole more than 1.6 milligram per kg per day, or MMI is more than 1.5 milligram per kg per day, and carbimazole more than 0.7 milligram per kg per day, or methimazole more than 1.2 milligram per kg per day, and carbimazole more than 0.5 milligram per kg per day, or methimazole 0.7 milligram per kg per day.
Next.
Okay, now moving on to question number 7. Which of the below mentioned finding differentiate thyroid hormone resistance from TSH secreting adenoma? We did had a case today. So option A, TSH levels more than 10. Option B, absence of circadian rhythm. Option C, increase in sex hormone binding globulin. And option D, response to TRH is normal or exaggerated. So pick up a finding to diagnose thyroid hormone resistance.
Next.
So question number 8. So the imaging findings of fetal thyrotoxicosis include all except the fetal neck measurement more than 95th percentile for gestational age, oligohydramnios, advanced femoral epiphyseal ossification, and fetal heart rate more than 160 beats per minute. Can I move on to the next question?
Yes, yes.
Yes. Okay. So question number 9. A total organification defect of iodide in congenital hypothyroidism is caused due to mutation in the gene. Option A, DUOX2. Option B, DUOX A2. Option C, thyroid peroxidase. And option D, thyroglobulin.
Next.
Next question. So now we come to the final one. Black thyroid, that is accumulation of pigments in the follicular epithelium that gives the thyroid a black colored picture in the histopathology is due to the prolonged use of which particular drug? Option A, fluoroquinolones. Option B, tetracyclines. Option C, cephalosporin group of drugs. And option D, lincomycin antibiotics.
Done now.
Thank you, Dr. Nivedita, for presenting the excellent quiz. So we will discuss the answers to the DM quiz first. Meanwhile, the tech team can get the results of the winners ready. And after the discussing the answers, we can announce the results of the DM quiz. We can start with discussion of the answers. Got it.
Yes. Can I?
Yes.
Yes, can I
Next.
proceed? Okay. So the first question we had was, which one of the following findings indicates neurological cretinism? And the option given was thyroid hormone replacement improves mental retardation, short stature, florid signs of hypothyroidism, and presence of deaf mutism. So the answer is presence of deaf mutism. So if we look here, the cretinism actually, like we classify into two types, neurological and myxodematous cretin. So severe growth retardation with short stature and presence of signs of hypothyroidism and improvement in signs with levothyroxine replacement is something which is typically seen with myxodematous cretin, but usually the neurological cretin, so they do not have any physical signs of hypothyroidism. They have normal state. And they do not have any effect with thyroid hormone replacement. So in addition, they do have a severe mental retardation. They have deaf mutism, squint, and cerebral diplegia. So hope it's clear. I'm moving on to the next question. So the next question was the human monoclonal antibody designed to target the neonatal FC receptor in Graves' disease, which is under phase 3 clinical trials. The answer is batoclimab. So these are the current drugs like which have been investigated with Graves' disease and thyroid eye disease in the pipeline. So they're all in phase 2, phase 3 clinical trials. And out of all the options available, batoclimab is one drug which is being investigated for Graves' disease. The other drugs like which we have seen in the options, so they're all being investigated for thyroid eye disease. And now moving on to the question 3, like which is a straightforward question. The drugs that increase TBG concentration are all except clofebrate, tamoxifen, nicotinic acid, and methadone. The right answer is nicotinic acid. So the drugs like which reduces TBG concentrations are pretty much less. Androgens, anabolic steroids, asparaginase, glucocorticoids, and slow release nicotinic acid. So now we are going with the question number 4. All are true about primary thyroid lymphoma, except yes, they do have a female preponderance. They occur mostly in the 6th decade and they are commonly B-cell lymphomas. The one feature is exposure to ionizing radiation is not a major risk factor unlike papillary thyroid carcinomas and anaplastic thyroid carcinomas. And mostly it is their autoimmune pathology, the underlying lymphocytic infiltration that later gets converted into a primary thyroid lymphoma. So now coming to the question number 5, which of the following is true about MTC? RAS mutated MTC behave more aggressively. No, it's RET mutated MTCs that have a very aggressive course. And the second option is the right one, that is F-DOPA PET, which helps in assisting with identification of occult metastatic MTCs. And of the drugs available, it's the vandatinib drug that has the maximal half-life inhibitory concentrations against RET of all the multikinase inhibitors available, and they are also investigated more with the trials. And 75% of MTCs are sporadic, only 25% is hereditary. So if we look here, F-DOPA PET can help with the identification of occult metastatic MTC. FTG is mainly for anatomical localization and spatial resolution. And DOTA-TET, higher sensitivity than FTG PET, and it's better for bone and lymph node assessment. And as I had mentioned, up to 25% of MTCs, they are hereditary and 75% are sporadic. So now, moving on to the question number 6. Alternative treatment with surgery or radioactive iodine should be discussed in children with Graves' disease who are on doses of at least carbimazole more than 1.3 milligram per kg per day or methimazole more than 1 milligram per kg per day. So they have at least when reached that particular dose, I think it's time to discuss other options. And this is from the 2022 ETA guidelines for management of pediatric Graves' disease. Now, moving on to the question number 7. So we did have this question in the case presentation, which of the below mentioned finding differentiate a thyroid hormone resistance from TSH secreting adenoma. So it's a straightforward answer. Response to TRH is normal or exaggerated in thyroid hormone resistance, but it is usually absent with TH, thyroid hormone resistance. So for TSH-HOMA, we have a serum TSH of more than 10. Normal TSH circadian rhythm is absent and sex hormone binding globulin is increased. So now moving on to the question number 8. The imaging findings of fetal thyroid toxicosis include all except oligohydramnios. Usually they have polyhydramnios because of the enlargement of the fetal neck because of the goiter, and the fetus will not be able to drink as much as of amniotic fluid. So usually they have a polyhydramnios picture, and the neck centile is more than 95th for the corresponding gestational age, and they have an advanced femoral epiphyseal ossification in contrast to hypothyroidism where there is a delayed maturation, and fetal heart rate, that is fetal tachycardia with rate more than 160 beats per minute. So now moving on to the question number 9. The total organification defect of iodide in congenital hypothyroidism is usually caused due to mutation in the gene. That is, it's straightforward, it's thyroid peroxidase, and the other genes are associated with partial organification defect. So now coming to the question number 10. Black thyroid is due to the prolonged use of tetracycline antibiotics. So prolonged therapy with tetracycline antibiotics, especially minocycline. So they help in accumulation of sufficient pigment in the follicular cells. So with this, I stop sharing the screen.
Thank you, Dr. Nivedita, for discussing the answers. I think it was a quite a learning experience quiz and the discussion to the quiz. Can we have the winners of the quiz, the DM quiz?
Just a minute, sir. We are just doing that.
Madam. Okay, I think the quiz was quite tough. So, I think 4 by 10 is the first mark. Dr. Sanjana, and second prize goes to Dr. HSK, and third prize goes to Dr. Shraddha Srinivas. So, congratulations to all the winners. So, you will receive a letter of appreciation from Indian Thyroid Society by email for having participated and won the quiz. So next we can discuss the practitioners quiz, which was conducted online before the session itself. We will have a quick discussion of the answers. Dr. Nivedita.
Yes, sir. 1 second, just. So, yes, okay. So now moving on to the practitioners quiz, they're all straightforward questions. And the most common cause of congenital hypothyroidism.
The screen has got stuck up.
So is this okay now, sir?
Okay.
The most common cause of congenital hypothyroidism is the answer is thyroid dysgenesis. So they
Nivedita, it's still your screen is not working.
Sister, screen is stuck up. I think you close the PPT and then open it again.
and share it. So actually, it comes as your screen sharing is paused.
I think now we can. Yes. Okay.
So that thyroid dysgenesis, they contribute to almost 80% of the congenital hypothyroidism. And the next question, the recommended time for screening of congenital hypothyroidism in neonates by venous sample is done between 48 to 72 hours. The ISPE recommendation for every newborn screening with a cord blood or postnatal blood, ideally at 48 to 72 hours of age. Now, moving on to the question 3, which of the following electrolyte abnormality is most commonly seen in patients with thyrotoxic periodic paralysis? So the answer is hypokalemia because of the increased activity of sodium-potassium ATPase pump. Now, question number 4. The recommended dose of levothyroxine in non-pregnant adults calculated according to body weight is 1.6 mics per kg per day. So we do have a range between 1.2 to 1.8, but most commonly it's recommended to be at 1.6 mics per kg per day. And now, in case of accidental ingestion of levothyroxine in children, the duration of monitoring should extend at least for 14 days. So because of the elimination half-life of levothyroxine, monitoring of vital signs should be carried out for at least 14 days post-ingestion with normalization level of TSH, FT3 and FT4. So the recommended antithyroid drug for Graves' disease in first trimester of pregnancy is propylthiouracil, option C. And because it doesn't have any birth defect, so most guidelines are proposed that recommendation of PTU in the first trimester should be considered, and to shift from methimazole to PTU in women planning for pregnancy. So now the next question, the female is to male sex ratio for Graves' disease is 10:1 because Graves' disease has a very high preponderance in women compared to men. Question number 8. The features of malignant thyroid nodule include all except presence of punctate echogenic foci, spongiform pattern, hypoechoic nodule, and ill-defined margin. The answer is spongiform pattern. So if we look here, In the composition, the spongiform pattern usually has a score of 0, and it almost looks like a microcalcification under a hypoechoic background sometimes. But typically, if we look in detail, the small pattern that looks like a sponge. So it is actually considered as a very benign nodule. And now the targeted immunotherapy drug used in thyroid eye disease that reduces exophthalmos is it's teprotumab. The answer is like the other immunomodulators, they help in resolution, but teprotumab helps in reducing the exophthalmos. So moving on to the final question, micronutrients involved in thyroid hormones are all except iodine, selenium, iron, and calcium. So the answer is option D. It is calcium, and almost iodine, selenium, iron, and vitamin D, even it sometimes like they're required in small quantities for supporting the key roles of thyroid. So thank you so much, everyone, for listening and participating. So with this, I hand over the session to, sorry.
Thank you, Dr. Nivedita. Thank you for conducting the excellent quiz and contributing to the practitioners quiz also. I think the discussion was very fruitful. Can we have the results of the winners of the practitioners quiz? So the winners of the quiz, first prize goes to Dr. Mohammad Gauss, and second Dr. Anish Kar, and third Dr. Prabhuram TS. I congratulate all the winners. You will receive a letter of appreciation from the Indian Thyroid Society by email. Thank you. Over to Dr. Pramila Kalra, Madam, our coordinator.
Yeah, thanks, Dr. Reddy. And I think this past from September last year when we started, we had an excellent series of thyroid clinics with discussion on varied topics in endocrinology, ranging from surgical topics to the clinical endocrinology topics to the molecular endocrinology topics to the quiz. And I know this quiz is one of the things which everybody looks forward to, especially the DM students as well as the practitioners, because we do quiz for both practitioners as well as DM students. And I think in today's discussion also, we had excellent discussion on the Strider and how these cases can present. And Dr. Narayanan also discussed on the presentations of thyrotoxicosis. So I think these things we have been having too much of insights and lots of insights into a lot of these things, which we normally see in our clinical practice. But I think more insight comes when we discuss these cases. And also the quiz part, we know that quiz for DM students is one of the things which they always look forward to. And I think that is that thing also today also we had a lot of students who participated in the quiz as well as the practitioners who participate online. And as today was one of the last of this series, I think we'll be starting again very soon. So I thank everybody who attended today's thyroid clinic, as well as the ones who have been part of the clinics from the beginning itself. And we know that our whole team, Dr. Reddy, Dr. Ganvi, Dr. Chitra, we all have been together organizing these thyroid clinics. And this was quite an interesting journey with Dr. Roma as well. And under the guidance of Dr. Sheshadri and our previous past president, Dr. Shashank Joshi. So our secretary has been very supportive, Dr. Arun, and Dr. Mini Pillai, our treasurer, has also supported us throughout. So we will soon be starting the new series of the thyroid clinics, as Dr. Sheshadri said, that once the new EC is formed next month. And I also request each one of you to please become a reviewer with the Thyroid Research and Practice Journal. It is a journal of the Indian Thyroid Society, and we need more reviewers to review the research which is submitted. So endocrinologists, endocrine surgeons, and people who are working in thyroid, I request all of you to please become reviewers for the Thyroid Research and Practice. You can just scan this to fill the form and become a reviewer. And you can put your timings, like whenever you need not accept every time the review. Whenever you are free, you can accept it. But it will help us to make our journal better. And also, I request all the students and all the faculty to submit their research to Thyroid Research and Practice, because this is the official journal of the Indian Thyroid Society. So then once we submit our research to this journal, we can make it even better. So these are the two requests from my end. And I just thank everybody for today's thyroid clinics as well. We are planning to put the next session on 13th August, but we will just discuss in our meeting, and then we will confirm that whether we'll have the next on 13th August or September, because we have ITS Con next month in Mumbai. So all of us will be going there and attending the ITS Con, and we request everybody to register for ITS Con, send their abstracts to ITS Con. The abstract submission is open, and you can submit your abstract for ITS Con as well. You can present your research work at ITS Con. So we have the portal on. You can go to the website of the Thyroid Research and Practice, and you can submit under ITS Con abstracts. That's how you can submit your abstracts for ITS Con. We have put the last date for 15 July. So please submit your abstracts to ITS Con if you have research on in the field of thyroid, whether it is nuclear medicine or surgical or it is endocrinology. So with that, I thank everyone, and including our technical team who has been with us throughout and who have helped us at every point, because we know that on the technical part that is the most important for the online clinics. So I thank them as well.
तस्य भासः सर्वमिदं विभाति।
So I think